I'm John Parkhurst. I'm a child and adolescent psychologist and psychology director of collaborative care here at Ann and Robert H. Lurie Children's Hospital. Work in the Department of Psychiatry, Pritzker Department of Psychiatry and Behavioral Science, and I'm also an associate professor at Northwestern Feinberg University. So our work has focused on outcomes, historically, as far as within the collaborative care model. And what we really wanted to do, we've always kind of had signals that we were improving confidence in independent practice of our primary care clinicians that were participating in our collaborative care model. But we wanted to see if that behavior aligned with their confidence. So our main goal was to see if we could identify prescribing, diagnosing, and quality metrics that aligned with what we think is good mental health care in the primary care setting. Yeah, so we built our model really focused on education and training. So the collaborative care model, as it's been designed and described elsewhere, has really been focused on the clinical practice. But we thought that what was really essential to collaborative care was providing that education and background for our clinicians to feel comfortable. And really, at the outset of this, this effort, which is really informed by what the pediatricians want. And the pediatricians were telling us that they would do the work, they would treat mental health conditions, but they wanted to feel confident in their diagnosis, and they wanted to feel like they had a team that supported them. So I think it was really two things. It's how do we have the how do we have the education, but also have a supported model that has the specialists and the people that you know who to call and when to call. So I think we leveraged the collaborative care model effectively along with the education that we provided them. Ultimately, I don't anticipate that we're going to make all pediatricians child psychiatrists, nor should they be. It really is identifying the right education and the right team to support them as they kind of move forward in building their confidence and capacity for addressing mild to moderate common mental health conditions like ADHD, depression, anxiety. Just to put a point on it, pediatricians and primary care clinicians are already doing the bulk of the mental health prescribing. So I think our approach is not that we just want to increase mental health antidepressant or prescriptions, but it's really about how do we do this in an effective and evidence-based way. So for us, it's about getting clinicians comfortable with the diagnosis and feeling really good about how to identify, track, and monitor progress, work with families around the diagnosis and treatment options, and then start to move forward in providing treatment and providing that access sometimes to medication, but also oftentimes also to psychosocial supports that are available in the community. So really partnering with clinicians to enhance their work with families, and as one element of that, providing prescriptions or medications that might support treatment. Well, I think it speaks to how these models aren't just for the clinical population that it's serving, but they also enhance the work of the clinician, the primary care clinician, outside of that specific supported model. So, really, what we wanted to see, and we're glad that we found an indicator of this, is that our clinicians were doing the work with the patients that we weren't providing consultation on or supporting with diagnostic support. So, that tells me that these models facilitate training. So, if these models can improve or reduce barriers for clinicians to jump in or start to do mental health treatment and do it in a way that we see as quality, not just prescribing or not just, because my back's against the wall and I have to treat this patient and they have no other access. I would love that to be the case. I would love that to kind of be the big finding from this is that these models can really enhance independence in providing care, good and quality care to children. Well, there's plenty of educational resources. We certainly ourselves have a free website that has CME for physicians to train and feel a little bit more comfortable in treating common mental health concerns. It starts with a willingness, and I think most pediatricians will tell you that they see a lot of mental health conditions, and they sometimes feel stuck and hamstrung by that. And in prior times, it might just be the desire to refer out or refer to a specialist, but people also know that that's insufficient, especially when wait lists are really long or there's barriers to their care. And so I think it's building comfort and confidence for these clinicians, primary care clinicians, to jump into some of the education around it and really learn that they already know how to do patterns for many other disorders. So it's patterns for mental health. So what are the early risk factors? What are the ways that I can screen or support my early identification? What are ways that I can communicate with families? What's information that I should just have in my back pocket so I can start to be jumping into this work? And then also, not just our program, but there are other statewide programs for psychiatric consultation. So it's knowing who your teammates are, who your psychiatric or your specialist teammates are, and there's usually are access points to psychiatry for at least consultation in various spaces. So that might be a tertiary hospital, but it also might be a statewide access line.